Good afternoon, everybody. This afternoon we'll be talking about screening of abdominal aortic aneurysms. And so there's a new Ontario screening program, and we can review how this is going to get rolled out and why this should be implemented in your practice. So we'll start with a case, Mr. Lucky. So about 5 years ago, we began to discussing with primary care providers with screening aneurysms in their practice. And within the first 2 weeks of one of our partners to begin screening, they identified this gentleman. So he's a 68-year-old gentleman, school bus driver, a remote smoker, typical blood pressure and cholesterol, very typical average patient that you'd see in their practice. No real surgery, no real admission history, hasn't really had any imaging. So he went through an aortic screening, and he had a 8-centimeter abdominal aortic aneurysm. He's a school bus driver. So that obviously could have been, quite concerning, fatal for him, as well as everybody and passengers involved. So we were able to do an EVAR for him. So what that is just stenting. So this is actually his images. Really big aneurysm, that's the big aorta. You could see the wires and the catheters up there. And you can seal this with stents. So fortunately, this patient went home, the next morning, was only off work for 2 weeks, and then back at it. So this patient always sticks in my mind when we talk about aneurysm screening. And I think it's really important that these patients are asymptomatic. So they don't have any symptoms. They really don't have much risk factors, kind of run-of-the-mill type of patients, and they can have very serious consequences. And today we'll talk about the risk factors for this and how this program is getting implemented. So what makes an effective screening program? There's a number of factors that play into a part of what would make an effective screening program. We have to know what the natural history of the disease is. It has to have a longer latent phase, so we have to identify these pathologies before we can end up treating it. It has to have a significant burden of disease, so it has to have a real outcome so that we're going to try to change it. You have to have a test that can identify it easily with high sensitivity and specificity. What we do with these test results have to be also relevant as well. So we have to have some sort of actionable result. An effective treatment, so a safe and effective treatment is very important to make a change in these patients. Has to be cost effective and then minimize harm. So these are the general principles, and we'll see how that applies to the aneurysm screening program. So what is an aneurysm? So aneurysms can occur in any artery in the body. And so that's a dilatation of the artery more than 50% as compared to a normal diameter of the artery. The most important thing to note, it is asymptomatic. If patients have symptoms of an aneurysm, that is very concerning. It is pre-rupture. Those are the patients that get, same day to the hospital, get treated right away because that thing is going to go. The aneurysms go quite slowly, so approximately 10% per year. So patients often have this for approximately a decade prior to having an intervention. So we really do know what the natural history is of aneurysms. They generally grow slowly, and when they get big enough, they rupture. So it's a very known, predictable, natural course of history. So what the criteria is for that, so for an abdominal aortic aneurysm, that's the threshold is 3 centimeters. And for iliac artery aneurysms, so that's kind of where the branch point is, that is 1.7 centimeters. The other criteria that plays into the realm is the shape of the aneurysm. So we see 3 different shapes here. We have fusiform, concentric saccular, and eccentric saccular. So these are different shapes of the aneurysm. It does play into the part of how quickly these aneurysms grow. So saccular aneurysms generally go quicker, and they have a higher risk of rupture. So generally, these get fixed at any size. It's important to note that the aneurysm length is not really relevant here. So it's only the diameter is relevant. So we get lots of, urgent calls for, 10-centimeter aneurysms, and that's the length that they measured. Not relevant. It's only the diameter that's relevant when it comes to aneurysms. So what are the risk factors? Number 1 is smoking. Very, very high predominance of this. Males much more than females. There is a strong family history that comes with this. There's a genetic component to this as well. Caucasian. If you have some sort of atherosclerotic risk factors, it can lead to aneurysms as well. So it leads to weakening of the walls, and then it can eventually lead to degeneration. So a number of these patients start off with a plaque that can rupture, weaken the wall, and then it becomes an aneurysm. So we call this, in the early phase, it's called a penetrating aortic ulcer. So you might see that term thrown around. And that's just atherosclerosis breaking down the aortic wall and can eventually lead to an aneurysm. So that's where hypertension comes in as an atherosclerotic risk factor. And then you have other factors, age, hyperlipidemia, and then, height. As, with increased size, you can increase aortic diameters. But the number one thing is smoking. So smoking is related to aneurysm, explains the majority of aneurysms. So how prevalent is an aneurysm? So it's a lot more than we think. This was the original study from the early 90s was looking at screening for aneurysms. So these are all patients above the age of 50, and they did screening. And so in men men that are current smokers, the prevalence was 6.3%, which is remarkably high. Former smokers, 4.5%, and never smoked, 1.6%. So even if your patient hasn't smoked, a 1.6% chance of an aneurysm above the age of 50, I think is still quite high. In women, the ever smoked was 1.5%, and never smoked was 4.4%. So the proportion is much lower here, but you'd note that in this study, which is the original one, the number of women screened was only 2,000 patients as opposed to over 100,000 patients for the men. That's very typical for most studies, but let alone vascular studies. Women are very underrepresented here. The more modern studies do appreciate that the proportion of aneurysms in women is higher. Definitely not as high as men, but that tends to be the risk factors, for this, smoking and atherosclerosis tends to be a bit lower as well. So what is the rupture risk? So what's our latent phase? How long do we have in this realm? So we're talking about a very, predictable aneurysm. This is one that is typically atherosclerotic, not a saccular, so a fusiform aneurysm. And this is an aortic aneurysm, not other locations. If the diameter is less than 4, it's a very low risk of rupture. It's very rare that I've ever seen anything rupture in this realm. Between 4 and 4.9 centimeters, it's 5%. And then above that, it increases quite substantially, 25% for above 5 centimeters. Above 6 is 35%. And above 7, it's 75% risk of rupture. So, generally we treat in men above 5.5 centimeters, in women above 5 centimeters, because yes, there are perioperative risks to these procedures, albeit low, so we do have to weigh the risk for intervention. And like we said, the growth is about 10% per year, so very predictable. So there's a very long latent phase that we can identify these patients with an aneurysm. We may be able to change the course, but at least we can identify these early and treat appropriately. It's very important to note that less than 20% of patients that have a ruptured aneurysm will make it to hospital, survive surgery, and get discharged. So, ruptured aneurysm is, the hallmark for all vascular surgeon care. We love doing them. We hope that we can get them through it. It's kind of like the highlight for a vascular surgeon. But I'll tell you, less than 20% make it through and make it home. These are very, dangerous procedures, very high-risk patients, and it's often too late. By the time they present at one hospital, they get transferred and get through care. These patients can get, long courses in the intensive care unit and barely make it through. So I think the significance of disease is very obvious. It's a very high mortality rate if you have a ruptured aneurysm. So what's the history of aneurysm screening? So a lot of the landmark trials for screening to show this prevalence and to show it's effective and we can identify them can vary between the early 90s to up to 2004. In terms of screening programs, the first one was in Sweden in 2006. The US really did implement theirs in 2007, although it varies state to state and how that would be actually implemented. The UK has a very strong, publicly funded aneurysm screening program. This would be the most ideal. That initiated in 2009. So we're a couple decades off of that still. There's lots of, political reasons for that. There's a lot of, challenges when it comes to implementing a screening program. Our guidelines have been very clear of who to scan, who to survey, and who to screen for years. So In 2007, our Canadian Society of Vascular Surgery had our guidelines written out. It was very similar to what we would see today. They're updated again in 2017. The Canadian Task Force on Preventative Care agreed with that in 2017, but it really hasn't become a screening program up until this past year. And that's what we can review today. So the Ontario Abdominal Aortic Aneurysm Screening Program really tried to simplify it. And so the recommendations are as simple as such. All patients, men, female, any risk factors above the age of 65 should have a one-time ultrasound to screen for abdominal aortic aneurysm. They tried to really simplify it. They've done a lot of different models on it between risk factors in men and women, but it's very clear that there's still benefit even in this very broad category of patients. So in your practices, that's probably a huge portion of patients that's coming through, and we can talk about what that would look like and why. But that's very clearly supported by the evidence, by our society, Canadian Society of Vascular Surgery, and by Ontario Health. And if you have a first-degree relative that has an aneurysm, that threshold drops even lower to 55, because there's clearly a genetic component. There may be a connective tissue disorder involved, and so it should be even younger for these patients. So how is it going to roll out? This screening program is a little bit different, I guess, to the other screening programs that exist for cancer and such. This is going to be a mail-out to all patients above the age of 65. This is the letter that's going to kind of going out to them. And they're doing it alphabetically. That's kind of how they're rolling it out for now. And the ask is actually to present to your primary care provider. So they're going to go to all of you individuals to say, what is this? What do I do? How I screen? As opposed to some of the other programs where, they can primarily, call up and get, their imaging otherwise. This is going to be going to the primary care providers to provide that screening and that advice. So this is actually rolled out into the fall, and they're doing it month by month, and they're doing it alphabetically. So this is what you're going to see. So how do you test? So what are you going to do when you present with this, or they qualify? The recommendation is a dedicated vascular ultrasound. It has a very high sensitivity and specificity. So to highlight that out of a screening program, it's a very effective test. There's no false negatives when it comes to this. Very few false positives. This is a very, very effective test. And the reason why you want to get a dedicated vascular assessment, because you need a very accurate assessment of the aneurysm, and we're talking about the diameter for these aneurysms. And so I've seen wild kind of reports where you say, you're reporting length, or they report a very large aneurysm or very small aneurysm, and we go and repeat the test, or we get an accurate measurement, and it's way off. We're not talking about a few millimeters, but we're talking about multiple centimeters. And that drastically changes the management. It also provides a lot of anxiety for patients. They've been told they have a very large aneurysm and they need surgery right away, and we come and do a dedicated vascular assessment, and it's below operative threshold. Drastic difference in the story there. A CT and MRI is not for screening. It's only for preoperative planning. If they have a CT, that does qualify as screening, if they've had it for other reasons. Particularly if it's a contrast study of the abdomen, that's totally okay. But you don't need to send them for a CT for screening. How not to test, a physical examination isn't going to help you. These patients are big, you can't really feel the aneurysm. Even as a vascular surgeon, we miss them all the time, so it's not really relevant any further. A general ultrasound is also not really relevant. They can be looking at the liver, the stomach. They might have one measurement of the aorta. They don't scan the whole aorta, and they can miss aneurysms. So I wouldn't qualify that as a test. And although you can pick up aneurysms on an X-ray, you can see calcifications and you can see an aneurysm, that's definitely not a way to test for aneurysms. So dedicated vascular ultrasound is the way to go. So quick, hands up, try to get everyone involved. So who here screens in their practice for breast cancer, colon cancer, prostate cancer? All right, it's more than most. Keep them up if or put your hand up if you screen for aneurysms as it currently stands. Okay, it's good roll. So in terms of the number needed to screen to prevent death, so breast cancer, it's around 1,700. Colon cancer, it's actually pretty low up there. It's 377. Again, the numbers vary, but within error for this. And prostate cancer is 1,400. So the number needed to treat to prevent death for an aneurysms is 216. So that is the lowest you'll find for screening this any type of pathology. It's very, very low. And the two reasons for that, or three, I guess. One is that there is a very high prevalence of aneurysms. We identified that previously. There's a very effective test. And if you have an aneurysm, there's a very high mortality rate. And we have tools to fix it. So 216 patients you have to screen to prevent one mortality from an aneurysm. The other benefit from aneurysm screening is cost is very low. It's to the system, but we take that into consideration nonetheless. So an aneurysm screening costs $80. That's what it costs for the system. So if you do on the math on that, to prevent death in one individual, 80 times 200 isn't very much. It's way lower than any of the other testing that we end up doing, way lower than a lot of the other preventative care that we end up getting involved. What's also relevant is that 25% of patients that have an abdominal aortic aneurysm have some sort of other aneurysm, iliac, popliteal, which are all relevant. They have, still their morbidity when it comes to them. So how do we treat this? The old school surgery still exists, open aneurysm repair. We still do a fair amount of them. This is, a big laparotomy. You clamp the aorta, you replace it with a plastic tube. We still do a fair amount of them. I would say it's only about 10% of what we do now compared to previous, but it works in certain anatomy and it works for young patients really well. What we do more frequently is an endovascular repair, an EVAR. You've probably seen a number of these. It's stenting. So at the Hamilton General, we have a hybrid room. So it's an operating room where we essentially have angiography and CT kind of at the same time. So I'd say the majority of our patients, 80-90%, qualify for this. We do some more advanced work as well, where it can go all the way to the chest, all the way to the iliacs, all endovascular, and these patients go home in a few days. So the majority of our patients do qualify for this. A standard EVAR, they stay overnight, they go home the next day, and the morbidity is very low with these. So we've done patients into their 90s under local anesthetic. Morbidity with this can be 1 or 2%. So there is a very effective treatment for this, especially when identified early. So what are the risks to screening? We do have to have a discussion around this. The ultrasound itself has a very minimum risk profile. I mean, doing an ultrasound, it doesn't really have much in terms of a risk profile. If you have a negative aneurysm result, that has a minimal psychosocial consequence. It doesn't. I'm sure people are relieved when they get the results. They have a negative aneurysm test. If you have a positive test for an aneurysm, it can elicit some anxiety in patients. Some of the tests that have been done around this and studies, they reveal that your anxiety returns to normal after about a month of diagnosis of this. And there's a number of ways to kind of mitigate that. One is to get education around the diagnosis of an aneurysm. Good we caught it early, what risk factors we can do to stop smoking and all those other factors to reduce the risk. Know that there's treatment options and it's not fatal in this realm and we can treat them early. Patients are happy to know that there's routine surveillance for this, so it's not like we just find these and we kind of leave them alone. We follow these every 6 months or a year to make sure that it's within, it's progressing stably and intervene when appropriate. And then prompt treatment when necessary. So once they hit operative threshold, generally these patients get into the operating room pretty quickly. Usually I say within the month of it reaching the threshold, and they're kind of back at it. So all these things can reduce anxiety for patients. And so this is very important when we're having any screening program, is how do we deal with the unintended consequences. We rolled this out over the past few months, and a number of doctors actually reached out. This came out from one of my physicians in Burlington. He said, so what if we find peripheral arterial disease incidentally? You do these screening programs, all types of screening. You can find things that you don't intend to find. Is incidental peripheral arterial disease relevant? And I would say it's actually just as relevant as aneurysmal disease. So if a patient comes in, they get an arterial study, and they find they have stenosis of the peripheral arterial disease or stenosis, is that relevant, and what do we do with that? So asymptomatic peripheral arterial disease is actually very relevant. So this is a chart of 5-year mortality rates in peripheral arterial disease versus other cancers. So the yellow one is peripheral arterial disease, whereas the others are between colon cancer, stroke, breast cancer and coronary artery disease. So at 5 years, a patient with asymptomatic peripheral arterial disease has a 30-year mortality rate, which is very high. These patients don't pass away from, limb-related events. They don't lose their leg, or, they don't have, an event with their leg and that's why they pass away. Their mortality is related to cardiovascular and stroke events. So if you have peripheral arterial disease, you have coronary disease, you have cerebrovascular disease, you're at high risk of a coronary event or a stroke. So identifying asymptomatic peripheral arterial disease is just as relevant as it would be for an aneurysm. These patients need to be aggressively risk factor modified. All of my patients that I see with this get sent to cardiology and they get appropriately tested. And they need to be on a statin, aspirin, the low-dose rivaroxaban, and they need to stop smoking. So the incidental findings that you would find out of this type of test is just as relevant as it is for the aneurysm itself. So how would you implement it in your practice? Again, going back to the guidelines, it's all patients above the age of 65. Again, very broad, but very relevant. Any patients that have a first-degree relative above the age of 55. And how we've suggested to get it implemented is you send for the screening and at the same time you do consult if abnormal. Because it's difficult to determine if this patient has a saccular aneurysm or an aneurysm in the iliac. What do you do with these results? I don't think that would be the expectation for you the primary care to manage that. That's our realm, that's our wheelhouse. And as we alluded to as well is there needs to be education around the aneurysm. We need to talk about first-degree relative screening as well. What if you find peripheral arterial disease? How do you manage that? Risk factor modification. And the treatment thresholds may vary. So, we talk about this 5 and 5.5 for men and women, but there's a number of factors that play into part of when we intervene. And we really do follow these patients very, very closely. So we try to avoid any loss to follow-up to make sure they get closely surveilled. So my suggestion would be is to request a vascular consultation if abnormal when you have this positive test result. So that's a summary of today's new Ontario aneurysm screening program. The recommendations have been out for a number of years, but finally we have attention from the Ontario government, Ontario Health to be able to report this. Again, patients are going to roll out with a mail and a letter to yourselves to how to screen and what to do with this next, and so we follow that advice. Hopefully the next era of this is that patients can self-refer themselves to locations to get screened, but again, there does need to be a bit of work to get this implemented for our patients. Thank you very much.
So we're looking at the first question.